Welcome to Healthcare Rounds, your insider access to the healthcare industry. I'm John Marchica, your host, CEO of Darwin Research Group. I'm excited today. Our guest is Alan Pannier, Senior Vice President, Product Strategy for SmithRx. And we're going to be going a few different topics today, but everything is around pharmacy and pharmacy benefits and pharmacy benefit management. So thanks, Alan. Thanks for taking the time. Appreciate your coming.
Yeah, John, thanks for having me. Excited to be here for a lively discussion of pharmacy benefits.
I get excited about it. I'm sure you get excited about it. Hopefully our listeners will be excited about it as well. So to kind of kick us off, I always ask to give a little bit about your background and just introduce yourself, but specifically, take us along your professional journey from your early Pharm D days until where you are today with SmithRx.
Yeah, happy to do so. It's I don't know that anybody in the pharmacy benefit space says they desired to work for a PBM when they grew up because they were a child, but here we are, right? So went to pharmacy school. After pharmacy school, worked in the retail setting, so worked on kind of the other side of pharmacy and was involved through pharmacy school, working for pharmacies, worked for a retail setting through Kroger, pharmacy grocery store chain that was owned by Kroger, prescription drugs. And what was interesting is it always was confusing to me, as I'm sure many pharmacists that are on that side experience, when you have a generic drug that's available, you're trying to help the patient get access to it, and then it gets blocked for a branded medication. And, in your mind, you're saying, why is this, this doesn't make any sense. It's more expensive. Why would anyone want to do this? But as I was going through school, got kind of stumbled into managed care pharmacy and ended up doing a residency specializing in pharmacy benefits and working at a PBM. And as I started diving in deeper, it was just the business side was fascinating to me, of the, how the drug supply chain works. And, you start learning about pharmacy network discounts and rebates with drug manufacturers. And you begin to understand, a layer deeper of, the answer to that question. Why does a patient being forced to use this expensive brand name drug? And it came down to rebates, right? And the incentives of these pharmacy benefit managers. Through that process, and after residency, I ended up working at a pass-through transparent PBM that was more regional in nature, but it was interesting because this was, in the 2010s, and at the time, pharmacy spend was maybe 10% of drug spend. It just wasn't, a huge focus for employers and benefit leaders as they were looking at managing their healthcare spend. And I always joke we were, probably 10 to 15 years too soon in selling a pass-through transparent business model, because again, it just wasn't a huge focus. But was there, we ended up getting acquired by a much more traditional, larger PBM. And what was super interesting on that side, or that front, was being on the flip side of it, being at a more traditional PBM and being able to really look under the hood and understand the ways and levers that are pulled in making money, and being a part of that. And so spent some time there, and only could handle so much, having conversations with clients and them asking, why is your drug spend going up? And my answer being, pointing fingers at pharma and saying, oh, it was the drug manufacturers and they're increasing list prices. But really knowing behind the scenes, it was us with all the levers we're pulling, making money. And so eventually ended up leaving and meeting up with Jake Friends, the CEO of SmithRx, and he had just kind of started SmithRx in kind of a similar business model to what I had started within the PBM space, which was more focused on transparency and a pass-through business model. And so came on board with Jake kind of from the beginning, and have been here the last 8 or so years at SmithRx, where I am today.
So you kind of answered the question that one of the questions I had for you is, how did that time kind of inform your philosophy on pharmacy benefit management today? And I think I'm getting the gist of that. But what I'm really curious about is, talk to me about your role as product strategy. What does that mean? What is your focus? How do you measure your success? Talk a little bit about that. I think, well, it would educate me, but I'm sure listeners would appreciate that as well.
Yeah, absolutely. No, it's, I'm definitely in more of a non-traditional setting, I guess, from the the premise of a pharmacist and graduating pharmacy school and what are you going to do with your life. But the easiest way to think about my role today and where I sit is overseeing all of the different levers that we can pull as a pharmacy benefit manager to lower spend for our clients. And so historically, pharmacy benefit managers have provided value really from two main levers. One is the pharmacy network in negotiating discounts with pharmacies on the cost of medications that'll be dispensed through their pharmacies. And then the second lever is through working with drug manufacturers on discounts, known as rebates, which are really kind of purchase discounts that exist in the space today. So overseeing the strategy and the work behind those two kind of main components of the pharmacy supply chain. And then the last piece is focused on really looking at drug mix and what are the clinical programs that we can do to ensure that generic medications or biosimilars, as an example, are being used and optimized, and really helping patients ensure that they're really getting the most out of their pharmacy benefit, but at the lowest cost possible for their employers.
So in a sense, it's kind of a financial role in a sense, but requires your knowledge and experience in the PBM space to be able to figure out these levers, as you say, right?
Yeah, exactly. There's definitely a clinical component to it in terms of, not every drug can be interchangeable, and, there's certain disease states that are maybe more high touch than others. And so there's not, always savings available. And so that's an important component of it that's more clinical in nature. And then similarly on the pharmacy discount side, and the just distribution of drugs, understanding, there's certain medications that have special handling requirements. And so we can't, force them to go through a retail setting.
Sure. So what I'm dying to get under the hood and talk about is sort of like these legacy PBMs. Now I think, you mentioned the manufacturers. Now I think there's more awareness among the general public of the PBMs, the traditional PBMs' role in escalating drug costs. And so what mechanisms, so like rebate models or AWP-based negotiation, hidden fees, when you think about that world, what do you see as most problematic, Alan?
Yeah, it's a great question. And to your point, I think even in the last 12 to 18 months, there's been more awareness raised. And it started really early last year with some of the employer-based lawsuits. So you have now employees of these large, self-funded companies like Johnson & Johnson and Wells Fargo and JP Morgan now as well, where the employees are suing their employer saying, you're not doing your fiduciary duty, meaning you're not managing your funds as a self-funded plan appropriately. And as a result, I'm being penalized either because I'm having high out-of-pocket costs or my premiums are higher than they should be. And then with that, you've got the, Wall Street Journal and New York Times publishing articles and both agreeing that these legacy PBMs are bad, and, they never agree about anything. And so they really become kind of in the forefront of the news, which has been great, and kind of exposing the games that really have existed forever. But I think the tipping point really has been the increasing amount of spend on the healthcare side that's going to pharmacy, right? As I mentioned, when I first got into the space, it was 8 to 10% of your overall healthcare spend if you're an employer, and now it's 30 to 40% in some cases. And so it's finally, enough is enough is kind of where we've gotten to. I think to answer your question, where are the problems? I think it exists in many different areas. What's interesting with the legacy PBMs is partly due to the vertical integration and the ownership that they have really across the entire supply chain, right? You take a company like United Healthcare where they own providers, they own pharmacies, they own the insurance side. They own the GPOs that negotiate with drug manufacturers now for rebates. I mean, they have the whole system covered. They've even started, manufacturing products, which is a whole different story we can talk about. But they really have, end-to-end ownership of the supply chain. And so that creates opportunity for misaligned incentives and driving revenue from the 100 different ways that they can make money.
So Wondering if you can get into the weeds just a little bit and talk about how excessive like AWP discounting, or the role of, you mentioned pharma prices, going up. Can you talk a little bit about how that distorts pharmacy reimbursements and disconnects uh, pricing from actual acquisition costs? Like, just a little bit, tease that out for us. And I've talked a little bit about this on the program before, but I would love to get your perspective on what's really going on in the pricing game and that spread and why that causes problems.
No, absolutely. What's really interesting with that is when you get to the heart of it and kind of how did we end up where we are today with all of the problems with drug pricing, a lot of it actually comes to back to the basics of the evaluation process that's done when an employer or a health plan or a payer is selecting a PBM, kind of the evaluation or selection process, the procurement process. So what's interesting is, if anybody that's involved with pharmacy benefits looks at their contract today that they have, right, their contract they have with their pharmacy benefit manager, what they'll see in that contract is an accountability framework that's what we call discount based, meaning that the pharmacy benefit manager is going to contract with an employer, a plan sponsor. And in that contract, there's going to be AWP discount guarantees. And those are typically in aggregate and they're by various channels. So as an example, there'll be an AWP discount guarantee for all the 30-day generic products. So it's like, okay, take the bucket of claims of all the 30-day claims that are for generic drugs. And as the PBM, I'm going to guarantee you that on average, the discount you're going to see is, let's say, AWP minus 85%. And then it goes down the list between branded drugs and mail order and specialty drugs. And then on the rebate side, it's similar. It's an aggregate guarantee that's typically per brand. So it's saying like, hey, on average for all of the specialty medications, I'm going to guarantee you, let's say, $3,000 per branded claim in rebates. And so it's all very much focused on discounts, and it doesn't really get to the underlying idea that's important for employers or plan sponsors, which is like, how much am I actually spending, right? And when you look at that and you look in the contract, it's impossible for you to say, okay, I'm going to spend $5 million on my pharmacy benefit next year because it's all just discounts. And the challenge with that is by having a discount-based evaluation process or accountability framework, what that does is it now incentivizes the pharmacy benefit manager to do everything they can to meet those guarantees. And unfortunately, in doing so, what that leads to is the pharmacy benefit manager preferencing higher cost products over lower cost products, or being happy when drug prices increase. So you think about it on the rebate side. If I've got, to pay an employer $3,000 for every branded specialty claim, and I'm going through and I'm, looking at it and I'm having conversations with a drug manufacturer. Well, if my current discount with the drug manufacturer is, let's say 30% discount on a $1,000 drug, so $300, well, the way that I can increase that amount is I can say, hey, pharma, increase your price, right? Instead of $1,000, why don't you increase it by 20%? And then all of a sudden the amount that I'm getting back is 20% higher. And that creates an incentive for me to, if I've achieved that guarantee I have, then I keep some of it or keep the rest of it. So what we've come into is this world, there's a simple analogy you could use that's fairly basic, but you think about, buying 2 different gallons of milk, right? You go to the grocery store and they're the exact same gallons of milk sitting on the shelf, and one is, has a 50% discount and is $12. So my cost is going to be $6, and one has a 0% discount and is $5. Well, everybody intuitively is going to say, well, I'm going to buy the $5 one. It's $5. But this this discounted framework would actually say, no, you need to buy the 50% discount because that one's got the best discount. And you ultimately end up paying more for that gallon of milk. And it seems simple, but that's what's happening, in a much more complicated way within pharmacy benefits.
And so it's almost like, whether it's the payer or the employer, let's just say that the employer is evaluating the pharmacy's spend separately, and that employee benefit manager, health benefit manager, whatever their title is looking at plan A or PBMA that's going to give me 85% discounts, and then PBM B is going to give me 87% discounts, then I know that since if everything is average wholesale price, if we all can agree on that published AWP, right? Well, I just want to go with the one that's going to give me the better discount. That's my thinking.
Yes.
Or you could same math with rebates, right?
Yeah.
As the top line price goes up, if your rebate is a fixed percentage, if that pie gets bigger, that dollar amount gets bigger, then my rebate gets bigger. So it's either I'm getting more on discounts or I'm bringing in more quote unquote money, if you think about it that way, in terms of rebates. But your point is well taken, but your point is it's the price it's the actual price, it's the actual spend that matters, and not however much that you're discounting, but the incentives in the system are such that the people making the decisions, employee benefit managers, payers looking to align with the PBMs, whatever, that their evaluation process doesn't even take into account maybe today it does, but say 5 years ago wouldn't take into account your model, which is totally different, which we'll get into here in a second. All of this sounds, and not wholesale acquisition cost, all of this sounds totally whacked.
Yeah, it's a great pun,
right?
Like, exactly. And that, I think you hit on a key point in terms of if I'm a benefit manager, right? It seems simple, right? The one with the best discount always wins, but that's under the two assumptions. One is that baseline, AWP cost is the same. So that's not taking into account changing of drug mix, which is what a lot of these kind of more modern new age PBMs do, which can provide significant savings. And so that's one piece that's missed. The other piece is the devil's in the details of the contracts in terms of the accountability. And so, something as simple as the definition of a generic drug. Well, the definition of generic drug and which drugs end up in that bucket can have huge differences on whether or not you're hitting those AWP guarantee targets. And so that's, there's the contracting process and definitions is fraught with games that can be played that make it so that on the surface, they're providing you that, percentage discount guarantee. And you think, oh, this is great. If I hit that guarantee, then yeah, there's going to be savings. But then when reality plays out, you're not hitting that because of the definitional games. And it makes it impossible to provide any accountability to that. And so there's two issues. There's the drug mix issue isn't taken into consideration, but then the accountability around, are you actually hitting or providing the value you're guaranteeing me in kind of the evaluation process is often missed.
Well, there's another layer here that I think, and I'm way out of my league in terms of understanding, so I'm making a whole bunch of assumptions here, but it makes me think of 340B in one sense. It astonishes me that, and I'm making no judgments here, it's just astonishing that there are people hired by, let's say, health systems as 340B revenue maximizers, right? Mm-hmm. And we're experts in maximizing the amount of revenue that we're getting from 340B. And the people who do that really well, they get promoted, they go on to other things, and right. I feel like there's probably a corollary on the employer side or even on the payer side in aligning with PBMs in the sense that, Sue Smith over here, that's a creative name I created. Sue Smith over here last year was able to extract a 92% discount level compared to the previous person in that role that could only get 85% discount. Or so-and-so employee benefit manager was able to extract so much in rebates, right? All of that takes away from the intention of what matters most, which is the spend, the actual price. In the same way that it feels weird to me, the 340B people in these health systems, again, no judgment, but that's not really what 340B was intended to be in the first place. It's just what it's resulted in, mm-hmm. and how now people are getting compensated for, and jobs are created that way. So there's this distortion completely around pricing. Am I getting that right, or does that seem wrong?
No, yeah, you're spot on. And what makes it difficult because it is focused on discounts is you'll go through the evaluation process. Your spreadsheet will show you, oh, if I, pick PBMA, I'm going to save $3 million on my healthcare spend. Well, then fast forward a year later, when you ask that same benefit leader, hey, did you save the $3 million? Oh, well, I don't know because drug price increased and utilization changed and everything else. And so it makes it actually nearly impossible to fact check whether the PBM did what they said they were going to do, which is again why we've gotten into this place that, every year or every 3 years, the benefit leaders will go through an evaluation process. They'll see some assumed amount of savings, but if that savings was happening, drug spend wouldn't be going up and to the right? It would be going down. And that's not what we're
Right.
seeing.
Right. So, transitioning then into the cost-based model, talk to me about the difference. And by the way, has it been, just before we get to that, has it been discussed in your industry that maybe you should come up with a different acronym, right? Instead of saying legacy PBM and now we're the new PBMs, maybe it's,
Yeah.
I don't know, pharmacy excellence or something. I don't
Yeah.
know.
No,
But anyway,
it's true. We're pharmacists, so we're not very good at marketing. So that's where we are.
so, but talk a little bit about the difference in your model, and why it matters.
Yeah, absolutely. So, and we're not, it's not necessarily novel, and we're not really the only pharmacy benefit manager out here doing this, but it's really shifting your focus. One, to have alignment. So I think one thing that's come out of the recent lawsuits for these larger employers is it's really been a wake up call for benefit leaders on your fiduciary duty, right? And are you being a good fiduciary or a good steward of your healthcare spend and your healthcare benefits? And so, step one of that is looking at your vendor partners and are they aligned with you in terms of do they have misaligned incentives, right? Do they have ownership within the supply chain that would cause them to make money in certain ways, right? If we don't own any pharmacies today, if we owned pharmacies, we'd probably be incentivized to use them, right? And so if I'm using those pharmacies and you know, those pharmacies are more expensive than maybe an independent pharmacy, right? Then you're not doing your fiduciary duty as an employer because you're picking a PBM that's driving up costs. So step one in that kind of evaluation process is finding a non-conflicted pharmacy benefit manager, which there's definitely some out there that you can work with. And then the second step of that is really getting back to what you mentioned on that cost-based approach is getting at what matters, right? Which is what are you spending on pharmacy benefits today? And it's pretty simple to do that, right? You can just add up all your invoices that you paid. To simplify it, to make the numbers a little smaller, we like to work in the framework of what's called a per member per month, where it's, again, fairly simple. You take your total spend, divide it by the number of members or belly buttons that you're servicing as the employer, and then divide it by 12. And then you come up with some number. Industry averages for the kind of legacy or older PBMs are typically around $120 to $150 per member per month. Pass-through PBMs typically operate around $100 per member per month. And then what we find with SmithRx and other more modern PBMs that are focused on changing that drug mix and really focused on lowering costs by looking at savings opportunities typically perform in that $80 to $85 per member per month range. And so you can see kind of the gradients of, you're starting at the top of the most expensive, spread model. You have no idea what's going on. It's a black box. You move to a more of a pass-through business model where it's disclosed and more transparent. You know what's going on, and there's a little bit of savings there. And then you look at changing that drug mix, and there's even greater savings. And that's really started over the last probably 3 to 5 years as we have, more savings opportunities, right? There's more generics for expensive branded drugs that are out there. Biosimilars have been huge for, really large products like Humira and Stelara that have been comprised of a huge portion of pharmacy spend.
So you mentioned, I want to go back to something that you kind of gave passing mention to, and that is with some of these big, legacy PBMs, without necessarily naming any names, when you have the level of diversification in the healthcare industry that some of these organizations do, talk to me a little bit about their conflicts, a little bit more, I should say, about conflicts of interest, and um, why it may not be such a good thing to go with one of these large kind of, we'll just call it a chain PBM.
Yeah. So it comes from a couple of ways, right? Part of it gets, and really the root of it is, at the end of the day, it really becomes a black box, and you have, no idea, the fees or the amount of money that a PBM is making, or one of these vertically integrated companies is making off of your pharmacy spend, off of your claims. Part of it comes in the more obvious sense, right, through pharmacy ownership. These pharmacies that are owned by the PBMs will negotiate for brand pricing with drug manufacturers on, like as an example, what's called an off invoice discount, where they, in addition to kind of the wholesale buying discounts they get other payments and fees that go to the, to the PBM or the owned entity. And those, aren't being passed through to the employer or plan sponsor, but those discounts are given on behalf of, the utilization and the spend of that employer. So they should have access to it. There's games that are naturally played with, drugs being more expensive. And there's been, public research on this, looking at Medicaid plans and state employee plans where the data is public on, the drugs cost more at these owned entities. And so that's maybe the most obvious issues that exist. There's two others within kind of the direct vertical supply chain, right? There's, these discounts with drug manufacturers that are called rebates have evolved. And there was more scrutiny. Even back in 2020, when President was in office the first time, he kind of threw out the idea of like, hey, what if we just get rid of rebates? Like, this is a game, it's a problem, like, let's just get rid of it and remove the safe harbor that exists that allow rebates to happen. And so what that led to is fear for these big entities. And so they created kind of shell companies that are called GPOs, or group purchasing organizations. So now all three of them own these other companies that are the ones that actually do the negotiations with drug manufacturers. And so what this allows them to do is to say, oh, I pass through 100% of my rebates to you, employer. What they're leaving out is it's 100% of what's passed down to them, not what's left up in that kind of shell company that's doing the negotiations with the drug manufacturer. But it's still within kind of, the mothership or the owned entity. And so it just allows them to, continue to play games. The most recent one that exists that's crazy is, as we talk about biosimilars, and the, revenue that was going to be lost because of the rebate take that exists, is now they've now all created manufacturing capabilities. And what's funny is, if you think back to the, late 90s, early 2000s, drug manufacturers actually created PBMs. Like in the beginning, it was Merck Medco.
Yeah, Merck Medco. I was just going to say that.
There you go, right? So what happened? The FTC looked at that and they said, hey, this seems like a bad idea, because if you control access to medications and you are the one making the medications, you're going to drive up costs. And so this doesn't work. You need to close those down. So slowly over time, right, the drug manufacturers got out of the PBM business. And now here we are 20 years later, full circle. You now have the big three PBMs that own drug manufacturing capabilities. And, for some reason it's okay now, right? And you can think of the misaligned incentives that exist there. The other piece that's actually not often talked about, but is a huge blocker for a lot of these smaller PBMs to operate and grow and be successful, is the ownership that they have on the medical side as well. And so if I'm an employer and I'm self-funded, then I will contract with a pharmacy benefit manager to manage my pharmacy benefits. And then I'll contract with somebody to manage my medical benefits as well, right? It's the equivalent, but on the medical side. Typically, these are called TPAs, or third-party administrators. Well, the largest ones are owned by the big three. So United Healthcare owns what's called UMR. Cigna owns one that's called Allegiance. And CVS owns Aetna and Meritain, which is a fairly large one as well. And so oftentimes we'll run into issues where where an employer wants to use SmithRx as a pharmacy benefit manager. And it'll get down to kind of the notification process and the implementation or integration process. And they have their medical benefits with one of those kind of vertically owned medical side. And on the medical side, they'll impose penalties if they carve out to a different PBM. Or they'll block it and say, no, like, you can't do this. Like, we won't integrate with that pharmacy benefit manager. And so even though it's a self-funded plan and they should be able to pick and choose everything they want, they're actually blocked and not able to do it. And again, it's just, another way of kind of protecting the market share that exists within the legacy PBMs.
Well, it smacks of antitrust issues, and I'm sure that that has been litigated and will continue to be litigated. It makes me think of another. I'm kind of go off topic here for just briefly, but we do. I mentioned, I think before this, a lot of research on health systems, and there's been this trend, as you're sure you're aware, of health systems building out their own specialty pharmacies. And yes, it's a revenue generator. We all know that it's a revenue generator for them. But I think that these, IDNs, they have a good point when they say, we want to be able to retain these people with these specialty meds because we see everything. We see all, their medical records. Our doctors are seeing them. They're getting their specialty pharmacies drugs through us, and we can. I think this is a good argument. I think it's a logical argument. We can provide better patient care because it's all tied in one. And what ends up happening is, a month or 2 or 3, then somebody's on a specialty med, they'll get forced out and switched out to whatever the specialty farms, the big box specialty pharmacy. And again, please don't send me a bunch of hate mail. We're not hating on big companies. In fact, full disclosure, she's not a pharmacist, but my wife works for Cigna, so it's all one big happy family. But again, kind of like a market distortion, that in the end, the patients maybe not be better off. And look, these big box specialty pharmacies, maybe they do a great job. I'm not suggesting otherwise. But intuitively, it makes sense that if you could kind of keep it within the realm of that health system, that the patient would be better off. There'd be less confusion, better communication. So it kind of feels the same. Now, one thing I wanted to hit on, because I know we've been talking now for close to 45 minutes, just from some of the reading that I did and some of the things that you've written before our conversation, I get a sense that you're an advocate for independent pharmacies, that you feel good about that there really should be independent pharmacies out there. Why is that? And what do you see for the future of independent pharmacy?
Yeah, it's a great point. And I think, to tie into your comments on health system pharmacies and just health systems, right, as entities, we have many health system clients today, and it's actually fascinating to go through the kind of evaluation process with them and have conversations with them as they're with these kind of more legacy PBMs for their employee benefits, and hear the restrictions that are in place, like you mentioned, where it's, you can fill maybe one fill at the specialty pharmacy that's owned by the health system, and then you've got to move it to our owned entity. Which is crazy to me, right? If I have an asset, and to your point, the patient care is better, which it is, that's what we've experienced with these clients, why not allow access to that? The only reason why is because of the revenue that's being made, right? And so whether it's working with SmithRx or any other independent pharmacy benefit manager, there's a lot of value for health systems in helping provide a better patient experience because we're open and we don't have incentives or ownership with pharmacies. And so absolutely, you can use your pharmacy to the most of your ability, and we can help you kind of maximize the use of the pharmacy in terms of driving patients there and helping them get there. And really, the other piece of it is setting up a contracting process with those pharmacies to meet the needs of the health system, right? Do you want your health system employee benefits to run really lean and the pharmacies reimbursed, maybe pretty aggressive rates like a cost plus type model? Or, do you want your pharmacy to be a profit center? And that's okay too, right? It's at the end of the day, it's your money in both scenarios. And so how do you want that money allocated? And we can help facilitate that. And it's been very successful for health systems that have finally been able to kind of move away. And I think the important piece of that is a great segue into independent pharmacies is the patient care that's delivered there, right? Many of these health system pharmacies are more or less an independent pharmacy, right? They have these deep relationships with the employees and patients that they're servicing, and it is a better experience, right? And I think that's holds true with independent pharmacies in general. As we talked about the kind of the discount-based evaluation process and part of why that's led to where we are today, well, that's also part of the reason we're seeing these independent pharmacies close is as there's been more and more pressure on like getting better and better discounts on the employee benefits side. Well, unfortunately, what that's done is push the pricing pressure worse and worse for independent pharmacies because you think of like a Walgreens or a CVS, right? They're bigger and they've got better negotiating power with pharmacy benefit managers. And so they're able to say enough is enough at some point. And so the only way that these PBMs can provide, those aggregate level guarantees to their clients is by reimbursing less and less to independent pharmacies because they have less, negotiating power and it's easier to just squeeze from them to meet those aggregate guarantees, unfortunately. Our belief is that the current pricing structure with pharmacies is broken, right? I mean, we're at, in some cases, AWP minus 95% as a reimbursement, and there's only 100%. So like, we only can go so deep for generic drugs. And so we've actually been on a contracting evolution over the last couple of years, moving our pharmacy contracts to some cost plus based model, whether that's NADAC or PAC or acquisition cost. We're kind of independent in terms of which one. It's more which one is the pharmacy most comfortable with. But our whole premise is we want to decouple drug pricing from the actual dispensing fee and work that it takes to for the pharmacist to provide care to their patients. And so we strongly believe that a dispensing fee that's more relevant to what it costs you to dispense the drug and to pay for the pills and the pharmacist to do the work makes a lot of sense. And you getting consistent reimbursement for every claim you dispense is better than making a whole bunch of money on some generic pricing arbitrage and losing a bunch of money on GLP-1s as an example, right? That just isn't a great business model for anybody. And we think that independent pharmacies and the value they provide out in the space is important to their communities. And it's important for us as well because, they're serving the patients that we work with.
Well, before we wrap up, Alan, a couple of final things. First, what do you hope that the listener, whether it's employers or pharmacists or policymakers, take away from our conversation today?
I think the biggest piece, I think, is just a general knowledge that there's options out there, right? I think the old adage that nobody was ever fired for picking IBM is kind of the adage that it's existed in the pharmacy benefit space as well, where it's you just go with the big three because that's just all you know, and you don't really know that there's anything different. But I think just general education that there are options out there, and they're great options and they're viable. They're thriving companies that are growing and being successful. And so I think as you're going through a procurement process, looking at other pharmacy benefit managers, I think is a great takeaway here. And aligning with, I think, the right pharmacy consultants. We didn't really get much into the pharmacy consultant benefit broker space, but there's misaligned incentives that exist there as well as we talk about kind of kickbacks and payments that are coming from these more legal that can make it so that you might think that your advisor is advising you correctly, but they might have some misaligned incentives. And so questioning, I think, how their fees work and how they're making money is an important takeaway.
Last thing, Ellen, I want to try something new.
All right, let's do it.
I've got 3 or 4 rapid fire lightning round responses. So this is no pontificating. This is just what comes to mind.
All right.
And then we can wrap up. So first, single biggest myth about PBMs.
Single biggest myth about PBMs, that you can save money by buying in bulk.
Most underrated benefit independent pharmacies offer.
I would say service.
I would agree with that. One tech trend, so AI, real-time data, that excites you in pharmacy benefits.
AI is super exciting. We're starting to dive in there. Oh, I can't pontificate. Yes, AI.
All right. And then your personal mantra or guiding principle in leading product strategy at SmithRx.
To always be curious and never be satisfied.
Love it. Love it. So how do people reach you? How can they engage with you on LinkedIn, or what's the best way to they want to get in touch with you?
LinkedIn works great. My email as well. So it's my name, alan.pannier@SmithRx.com. Feel free to shoot me an email. Happy to respond and set up some time, and love to have lively discussions about pharmacy benefits.
Great. Well, thanks again. Really appreciate it. That'll do it for another episode of Healthcare Rounds. Our guest today, of course, has been Alan Pannier with SmithRx. I'm your host, John Marchica, CEO of Darwin Research Group. And listen, do us a favor. Leave a rating on Apple, Spotify, YouTube, wherever you listen to the show. And if you haven't already, make sure to follow us and on LinkedIn, healthcare, and on YouTube and other places. So thanks again to everybody. Alan, thanks. We'll see you next round.
Thanks, John.